Good afternoon, good afternoon, everyone, and welcome to today's roundtable discussion hosted by Health AI Institute. My name is Ikram Khan, Senior Fellow at Health AI Institute, and I'm delighted to have you join for this important conversation on ensuring AI safety for vulnerable users in mental health. The Health AI Institute is dedicated to advancing the integration of AI into healthcare and life sciences. Our mission is to foster collaborations, drive innovation, and create policies that transform care delivery and promote equitable healthcare access globally. Today, we are honored to welcome Dr. Declan Grabb, a forensic psychiatrist at Stanford and the inaugural AI Fellow in Stanford Lab for Mental Health Innovation. Dr. Grabb brings a unique blend of clinical, academic, and industrial expertise. His groundbreaking work focuses on AI and user safety, especially in mental health, and his research has earned national recognition for its transformative impact. Dale Good, along with me, will be moderating today's discussion. He is principal at Justice Technology, who brings a wealth of experience in technology, justice, and ethics. Together, we will help to explore the risks, opportunities, and ethical challenges of using AI in mental health care. Let's get started with Dr. Grabb's presentation, followed by moderated discussion and Q&A. Dr. Grabb, the floor is yours.
Perfect. Thank you so much for the introduction. I was apologizing that I will have a little bit of ambient noise. So let me know if you have a problem hearing me at any point. I'm going to go ahead and just share my screen really quickly so I can go ahead and get my slides on here. Let me know if you can see everything. Can you see everything okay?
Yeah, that's perfectly good.
Perfect. Yeah. So I'm a psychiatrist at Stanford. I'm working in the Brainstorm Lab, which is Stanford's Lab for Mental Health Innovation. And this is just a talk on sort of AI and mental health and AI and mental health care. So an intro for the talk is that essentially we'll just kind of go through the current structure of what mental health care is like if you're a patient and if you're a provider, maybe how AI can be infused into mental health care, and then lastly, some of the risks of AI in mental health care. I always start with this slide here because I think that it sort of grounds you in how society sometimes appreciates new technology. There's always a period where people are very excited. And then there's oftentimes something called a trough of disillusionment, where people then realize it's not going to fix every problem and they maybe want to give up on it. So oftentimes when I'm giving a talk like this, it is over sort of like video. And so I always try to use this slide. I think right here is a good demonstration of the power of models over the last year or two, where you can see an image that was generated using a model on the left, and then just a year later, you can look at an image that was generated on the right. You can see that the ability to sort of generate images has increased dramatically due to increases in compute, data set sizes, and parameters of the models. And I think this is a good visual demonstration if you think about no longer just image generation as a capability, but maybe medical management or psychotherapeutic techniques. You can think about our models sort of just increasing in power in a lot of different settings. When I think through what makes a patient-provider relationship meaningful, whenever I'm working with patients, I oftentimes feel like the therapeutic dyad. So myself sitting with a patient, and then the information that I can give them, like medications, therapy, or insights, are what they find it to be helpful for. Things that make it painful are oftentimes the cost of the visit, how long the visit takes, how long it might take to drive there and park, the fact that if I move on, they have to meet a new provider who might be different in various ways. And so I think about how this dynamic might change if everyone has access to reliable, personalized medication information and psychotherapy for free. It suddenly changes this calculus where we have to refocus on what do we actually bring patients. And I would argue that it actually centers more on the therapeutic dyad than it does access to reliable expertise. This is also just a helpful frame to show that more than half of mental health care visits are conducted via telemedicine now as of 2024. So if you're thinking about the therapeutic dyad of the human relationship, sometimes that's already removed, even from your encounters if you're not always in person. Some of our research has looked at various tasks and subtasks in mental health. When you're looking at an AI model's ability to complete various parts of the healthcare system, you have to divide it down into tasks and subtasks. And so we sort of said that triage was an important task, diagnosis was an important task, treatment was an important task, monitoring was an important task, and then there are administrative tasks too. Um, and we said you would have to be able to ask various AI models to accomplish these various tasks and subtasks before you could sort of say that it was able to really augment the delivery of healthcare. This sort of research is not new. People have been working on AI in healthcare since the 1970s. This is one example of that. This is something from the paper that sort of shows how a model might be able to provide treatment in the form of medication recommendations or therapy recommendations. It might increase its diagnostic certainty as it sort of reviews information about a patient over time. It may continuously document all of the interventions. It may provide some, insights into biometric data collection if it's seeing how many steps you're taking a day, how many hours of sleep you're getting in the night. And it also may help with crisis monitoring. If someone has like a mental health crisis in the middle of the night, oftentimes they can't reach their provider. So this paper, we tried to create a framework of what would it look like if you had AI in the healthcare system, and what are the various ways that it could sort of improve things, and where does that also present risk. And so I always go to this slide here where this is a survey of folks in like 2022 before AI became very popular about how comfortable they would be receiving a diagnosis from a computer program if it was right 90% of the time compared to if it was right 98% of the time. What you can see here is basically that folks, even if they couldn't explain necessarily the rationale behind why the diagnosis was being made, they become more comfortable with it as long as it's increasing in accuracy. So you can just sort of see, even if folks don't understand the black box of an AI model, if they know that it's more accurate, they are going to have more confidence in it. Again, even if they don't know why it's doing what it's doing. Here's just a slide that sort of shows that folks are already using ChatGPT and tools like that for therapy. And so, this is not a discussion of like, should this happen, but it already is. So how do we make sure that it's safe for the folks who are doing that? And I think here also highlights there are a lot of competing incentives when they talk about AI and mental health care, that a lot of folks see it as like, maybe a way to revolutionize things and they like the idea of innovation, but maybe they're also someone who is working for venture capital or other sort of like, I would say capitalistic sort of enterprises where their goal is to make money. And there's a lot of money to be made, right, in AI and mental health care. So you have to sort of assess the incentives of whoever is proposing new sort of interventions. This is a graph from the paper that we had put out that essentially assessed all of the state-of-the-art models on their ability to detect and manage mental health crisis. Red is bad, orange is middle, and blue is safe. Safe doesn't mean helpful, but it does, just mean safe. So essentially here we found that a lot of the models, if they were accessed by a user in mental health crisis, were actually giving harmful information. That could take the form of like giving them methods of suicide, to colluding with their delusions or not recognizing their mania. We tried with the computer scientists at Stanford to fix some of that, which is the graph on the left. But unfortunately, a lot of the quick fixes we tried weren't really effective at improving the model's ability to respond. This is another paper that we have, which is actually why I'm traveling to present this. But this work is essentially looking in at the black box of an AI model and seeing how does it internally represent concepts like suicide or mental health concepts. And can you basically, if you identify internal features of AI models that correspond to these concepts, if they're bad or harmful concepts, can you ablate them or can you get rid of them? And does that make the model safer? And so you can sort of see here an example on the left where we prompt the model with a neutral sort of prompt, and we identify a feature that relates to like mental health crisis. When we amplify that feature, it makes the model more unsafe. And when we ablate the feature, it makes the model more safe. Here is some work we've done in like image generation tools where you can see just the bias in terms of how image generation models depict mental health. And we looked at how that sort of intersects with various demographic information. I don't think there's a very easy solution here, but we did want to point out just when you are using these tools to generate images, they come with a certain level of bias in terms of mental health. Drawing from the research that we did about the risks of AI in mental health care, there's obviously been a lot of high profile situations where people have experienced harm when accessing AI powered tools in mental health crisis. And the character AI situation is one. And you can see various headlines that relate to other sort of situations here. And so, our lab worked with Common Sense Media to try to distill down a lot of the literature, a lot of the research surrounding AI companionship and mental health and AI, to sort of come up with like a guide for families, even to sort of help them understand how teens can maybe safely engage with this technology and what things they should sort of look out for to avoid situations like this happening. We also worked with an organization called ML Commons in improving their benchmark. A lot of companies create benchmarks to assess the efficacy, power, safety of AI models, where they're essentially just thousands of questions that you can pose to an AI model and see how accurate it is. So our work with ML Commons focused on helping them with their suicide and self-harm questions, where we created a framework to help them identify how to sort of assess model safety in the realm of mental health. And that involved explaining to them sort of, when a user is typing something into the chat box, it's not enough to just sort of use keywords like indexing on things like suicide or kill myself or anything like that. You actually have to get a little bit more granular and understand sort of the intent and the motivation behind the prompt, because that helps you understand how dangerous it is, or maybe it's just a benign inquiry about facts related to suicide or statistics. And so we sort of created this framework for them that they could use to label their own information and more specifically sort of assess the safety of their models. And further, we'll sort of expand this category to include things like psychosis and mania, but we felt like this was a good step. One of the last things that I was going to touch on is essentially there's been some research on how large language models are used in diagnostic settings. And do they help doctors? Do they hinder doctors? I think right now there's not a lot of good information either way. This one came out recently in the New York Times, and so it's something that people have been talking about. But basically, the primary outcome of the study was looking at diagnostic reasoning and seeing if using an LLM was something that might help physicians. It seemed like it didn't really change much. But some of the criticisms of the study were essentially that they didn't, provide clinicians with instructions on how to use these tools, because a lot of them in the study were using it for the first time. And then a secondary outcome of the study was that when they looked at diagnostic accuracy, which is separate from diagnostic reasoning, they found the model to be more accurate than healthcare providers, which was obviously the headline that the New York Times was interested in running, even though it wasn't the primary outcome of the study. But I do think this highlights there are interesting things to pursue here, right? Like maybe if you onboard physicians and teach them better how to use these tools, I could imagine that they would enhance diagnostic reasoning, just like folks use UpToDate now, and maybe a few decades ago people couldn't have imagined that tool. I imagine this will sort of work its way into the healthcare system and supporting physicians and other clinicians. This is just more sort of detailed information on that study in particular, and then some of the criticisms that I had talked about already. I will say that I think I will probably actually end here, and I'm happy to answer any sort of questions folks have and make it more sort of like a dialogue than a presentation. My main takeaways are AI in healthcare is a decades-old phenomenon. There's renewed interest, obviously, because of the power of language models and neural networks right now. I think it offers an incredible opportunity to democratize access to mental health care and augment the capabilities of providers, so we're spending less time writing notes and more time being with patients. There's definitely risk associated with it, especially in the mental health setting, which is what a lot of my research and work is focused on. But it will yield the time so I can answer any questions.
I have a question. So so you mentioned this ML Commons and some of these tools, these AI tools. Is the tool intended, it's not to interact with the patient, it's to interact with the clinician to give guidance to the doctor to give to the patient. Is that correct?
So the ML Commons is not like centered on healthcare. So ML Commons is a nonprofit that sort of sits at the intersection of a lot of different technology companies, and their goal is to create various benchmarks. So just think of it as like a board exam for like medicine, right? You create a test and you make sure that your questions are really good, so you can give it to a bunch of different people and see how they do. They do the same thing where they work with a lot of different experts and they try to create really good benchmarks or tests, and then they give those to all of the AI models that exist. And so they try to sort of be a nonprofit and unbiased entity that essentially says, like, we worked with a lot of experts, and your model in these 13 different hazard categories scored really well in 1 through 7, but 8 through 13 your model scored really poorly, so we view it as unsafe in these settings, whereas it can be safe in those settings. So it's not quite like healthcare, it's more general use. So the work that we did was focused on suicide and self-harm. So we were trying to help them come up with, like, how do you better understand that category? How do you better create questions? And how do you better evaluate safe responses from models?
So it really is to help the physician and not to interact directly with the patient. My concern is, we're kind of in this crisis of loneliness now. With social media and cell phones, I mean, people are just so fixated on the technology, and these technologies are 30 years old or less. So, human beings have had very little time to, acclimate themselves to these rapidly changing technologies. So I'm very concerned that by using AI, and especially quantum powered AI, if that is further eliminating the human interaction, that we may not see an immediate, and there may be an immediate positive, but a long-term socioeconomic, cultural harm. So react to that, not necessarily to this. I think I had that wrong.
Yeah. I think, no worries. I think so one of the questions I would say is, like, I would first draw a distinction between, right, like health, like applied AI in healthcare settings, and then like general use technology. So a lot of like the safety work is in general use technology. So it is like if someone's suicidal or psychotic and they go to Google and they start to search that stuff, right? Someone has to make sure that the information that it's providing that like is clinically sound, even though that's not like an applied healthcare setting, if that makes sense. And so I view this AI safety work in a similar way. You want to make sure that like the general population, when they're using these tools, that they're accessing like clinically sound and safe information. The second piece, which is like about sort of like applied in the healthcare setting and over reliance on technology, like I think that's separate in my mind, but I agree with you that essentially there's a concept of over reliance, right? You can see that, there's a correlation between screen time and various mental health outcomes. Like in young people and adults, screen time is not all the same. So they actually find in research on social media is that it depends on what type of screen time you're using, right? It depends on what type of information you're accessing, and it depends on like how you sort of feel about the information you're accessing. So it's not as simple as saying like, oh, if you spend 2 hours per day versus 8 hours a day, you're going to be, unhappier by this percentage. But it's sort of similar where it's like folks are spending an increasing amount of time online, and then suddenly you have these anthropomorphic technologies that are really empathic. Maybe they're sort of simulating human interaction, and now you have a loneliness epidemic, and folks are turning to what feels comfortable in the moment, but in reality that might be even more isolating because it's cutting them off from like real human connection. And in a similar way, I think we as doctors have sort of seen, healthcare technology in the form of electronic medical records was employed in the healthcare system more to sort of support billing and those sort of administrative tasks without clinicians being at the center of it. So it's something that then felt like onerous and not helpful to the physician. Whereas I think a lot of these AI powered tools have the clinician more centered, where it's something that it's sort of, helping with, it's like an AI scribe, it's like helping with documentation. It's sort of actually like easing some of that burden for the clinician in a way where I think you can refocus on being with the patient. Whereas like some of the electronic medical record stuff of the past, it feels like was hyper focused on billing, but that's sort of my sense.
Taking time away from the patient instead of adding time.
Mm-hmm.
Okay, that helps. Thank you. Any other dupes? I'm not sure where we're at here. So this was the AI and mental health risks, industry solutions and research. Do you want to go into that, Dr. Grabb?
Sure. Yeah. I mean, I think that's one thing that has been really meaningful, I think, about my work in the Lab for Mental Health Innovation at Stanford, is that it's one thing to do research and talk about it at conferences to other researchers. It's one thing to sort of sit in a room with a patient and share some of your knowledge with them, right? I think it's very different to take all that experience, like clinical experience, and then sort of like research understanding, and to try to kind of communicate that at scale, right? So some of the work, right, focuses on working with companies or other organizations who want to understand, like, okay, how do we think about depression and how that interacts with AI-powered tools? How do we think about schizophrenia and how that interacts with AI-powered tools? And so you're able to, I would say, kind of take some of your clinical experience, your research experience, and you try to make that information very accessible and digestible to an audience that has I would say a higher reach, a reach at scale. And so some of that work is with Common Sense Media, where we work on questions of AI safety with them. So our lab sort of provides clinical insights into, here's how various vulnerable users might be harmed by AI, and here's how you might use technology to help them. And here are things to look out for. And so that takes the form of helping them understand primary literature. It takes the form of helping them create guides for families. And our work with ML Commons was similar, where we sat down and brought our clinical expertise to sort of, they're very, I would say, like technology focused and AI focused solutions. We sort of brought in our clinical expertise to sit down and say, like, here's actually how we think about self-harm and suicide based on our experience with patients, and here's what are evidence-based responses and things like
that. Any more on this industry solutions and research topic?
No, I feel like that's a pretty good sense, yeah, of what we do. Basically, the lab in the past has worked with companies like TikTok, Apple, similar sort of stuff, where it's like, how do you make sure that these applications are not harming people, essentially, and how do you use your mental health expertise to make that happen? And I think social media was one of the big things in the last decade. And I think generative AI is sort of the second thing now, where folks are sort of realizing, like, social media came out, no one was paying attention to mental health symptoms, and then we realized all the negative consequences. So now as generative AI is kind of rolling out to the public, I think folks are trying to be more thoughtful about how do we make sure it doesn't do any harm.
Right. I read this article. You may know this gentleman, Dr. Kopp, Maurice Kopp, the quantum ELSI, the novel field of research, and the ELSPI stands for ethical, legal, social, and policy implications. And I just thought that's an interesting framework. Kind of the holistic sort of concern of, with this new technology, all those dimensions to the concerns. So is that something you bumped into, or so it's the legal component, there's a societal component, there's an ethical component, policy component. So you feel like that's all something in your research, that all of those dimensions is something that you're.
Mm-hmm. Yeah, I mean, I would say in a way, in that I'm like the forensic psychiatry fellow at Stanford, so we do sort of sit at that intersection of the law and medicine and mental health. My work is focused on a lot of safety, though, and not like the legal implications. There are certainly people at Stanford and elsewhere, I think, that are answering those really interesting questions. I think about, like, like, but if you think about like malpractice, right? Things like that, if suddenly like AI is, making recommendations and summarizing documents for you, if you were to follow an algorithmic recommendation and someone experiences harm, is the onus then on you as a provider, on the person who provides the algorithm? I think there are a lot of interesting questions there. And similarly, when situations happen where AI models don't recognize that someone's in crisis and something bad happens, where does culpability or liability tend to be allocated? That's not quite my research area, but it's something that I think is really interesting.
I think that would be, that whole section 230 and how, 230 does not apply to the internet. The internet is a platform, social media is a platform, and it's not, providing, it can't be held legally accountable. So I'm not sure, does that also apply in your research? Does that all that, that hole in section 230 in the federal code, does that provide an escape for this healthcare AI or not?
I am not a lawyer, so I'm not going to touch that question,
Yeah,
but I do think that it's an interesting one.
Okay. I'm sorry. I'll follow up on that one. Thank you. That's my questions. Declan, you wanna?
Thank you so much, Declan. It was very inspiring presentation and a lot of interesting questions from audience. So I've grabbed a couple of them, and I can go and try to see that's how much I'm able to cover up. So one is that, do you see a need for a specific regulatory framework to govern AI interactions with the users in crisis situation like mental health? So it can go in many different ways. If so, what key elements should these frameworks include?
I think like a question about regulation is always very interesting because I think it's our immediate reaction to any form of risk. This is just me speaking as Declan, I think that what would make the most sense in how you mitigate these sort of technologies is not to sort of have a reactionary regulatory response where companies just sort of try to meet whatever minimum requirements someone happens to write down in law. I would also say that regulatory solutions happen at the local level, the state level, and the federal level, and the global level. Right? It can form like the EU AI Act versus like California trying to pass legislation. And so many of these regulatory frameworks, if they're law, sort of create this patchwork of like different expectations based on where you are. And it's very difficult when you have a pretty general use technology. So I think one of the things that is more interesting, I think, is like the ML Commons work, where you suddenly sort of create an ecosystem where you say, like, here's a really good test about how safe your model is. And you suddenly have a commercial incentive to perform well on that. Meaning, like, if you're a model developer, you're someone who's creating the next like AI model, it looks really bad on you if you perform really poorly on the AI safety benchmark. So you're incentivized to make sure that your model is safe. I think that sort of translates then from like, as opposed to like hyper specific local policy, that sort of incentive is disseminated throughout like an organization regardless of borders and things like that. So in my mind, a lot of the work comes on like creating really good benchmarks and making sure folks are like incentivized to perform well on them. That's my short answer.
Yeah, great. So I think there's a couple of questions on the common sense media which you mentioned. So the other questions from the audience, that's your work with common sense media on AI companion is fascinating. So what are the key risks and opportunities for integrating such tools in mental health intervention?
The tools of AI companionship.
Yeah.
I would never view as like, I would never create an AI companion for an individual and call that like a mental health intervention. Rather, the way that I would maybe take that question, I would say, how can you sort of deploy some of these AI powered tools to like help clinicians? And one of the ways that I see it is like, if you see a patient once a week or once every other week for therapy, what are they doing all the other days of the week? Tuesday, Wednesday, Thursday, Friday, maybe you see them Monday. I think there's certainly a role for technology that fills that gap. So maybe there's like an AI powered tool that coaches them through the therapy homework that you gave them and documents how well they do it. and then highlights for you in the next visit what the challenges were and how well they did the homework. And it sort of coached them along the way, even when you weren't there, so that maybe their outcome is better had they never even, had that tool. So I view it as sort of like extending the reach of the clinician, but definitely not like replacing it.
I think that's a very interesting insight. That's how technology can help and assist clinicians. So the questions from audience, that's how can clinicians, computer scientists, and policymakers can collaborate more effectively to ensure AI tools are both safe and beneficial for mental health care use cases?
Yeah, I think that's such an important question, and it's one that I'm grateful that I have like the Lab for Mental Health Innovation at Stanford, because it sort of sits at the nexus of a lot of different folks. And so I would say, like, you have to, as a clinician, like walk into rooms that are not all doctors. You have to, like, if you're doing research, you have to like do interdisciplinary work with like computer scientists. If you want to like impact things outside of like a hospital or a clinic room, you have to like go to that space and you have to convince those people why your opinion is worth something. And I have found that I think when you do that, you have really like great collaborations that are meaningful, and you also create something of a lot of value, because that sort of interdisciplinary collaboration doesn't happen a lot. So I think really you have to kind of know your own personal circumstances, but wherever you're at, sort of like find the folks who are adjacent to the work that you're doing, that are sort of outside of your field of expertise, and try to collaborate with them. That's one of the really helpful ways, I think, that we can sort of improve this.
Great. So other thing like to understand based on your research, what are the most critical risks generative AI poses to vulnerable population, particularly individuals experiencing suicidal thoughts or psychosis? How should these be prioritized for mitigation?
Yeah, exactly. I think that's exactly it. Is like people with suicidal thoughts, psychotic users, and manic users, I think, are what we're finding in the research to be like some of the more vulnerable folks. Like if you're looking at how poorly these models detect those symptoms and how they give harmful information, I think mitigation efforts are exactly what I described. Like I think that you need to work on like a good benchmark, so people are incentivized to care about these things, because if you can give someone like a D plus on managing suicidality, they're going to work hard to make sure that they can get like an A. And so I think that that is one way. And then secondly is I think that sort of working in this space, doing research on it, highlighting key failure modes, like when you're doing your own work. Like, we all have sort of like uh, our own specific understanding of how AI may fail in giving patients advice based on our own medical specialties. And I think that highlighting that in the form of like research papers, things like that, is another way, I think, to get the attention of people who are developing the technology to make sure that it's safer.
Great. So your research on bias in AI models for psychiatric diagnosis is critical. So how can we better design AI system to minimize these biases while maintaining clinical relevance?
Yeah, I think I do not train models, but I would say that there's pre-training, right? And there's post-training. And I think that pre-training means that you're making sure your data sets that you train your model on are representative of the population and are not like kind of reinforcing any biases. Post-training is sort of what you do to like mitigate things after the fact that you've trained your model. Um, and that comes in the form of having like humans align their responses and pick the ones that they think are best. And I think making sure you have like a diverse group of people doing that is another way to make sure that like your model is aligned in a way that doesn't do that. And I would say lastly, like sometimes you can think of it as a mirror, right? Like all of these biases exist in society, and that's why they're present in our models. So I think it also is just a moment to sort of like give everybody pause to sort of be like, oh, we're really focused on removing this from our AI models. How do we then sort of focus on removing it from society?
Yeah, I think that's very interesting perspective that we have everywhere biases are there. That's a good response. So coming from you working in mental health and AI, so what are the emerging trends you see in AI in mental health integrating, and what you are more optimistic about, and where do you think the next breakthrough will occur?
Yeah, I mean, I think I'm optimistic about it extending the reach of clinicians in the way that I described, both in terms of like removing some of the burden of administrative tasks, and then also like extending the impact, kind of like what I described on like the Monday, Tuesday, Wednesday sort of thing. Um, I think, one of the things I worry about is there are a lot of perverse incentives in sort of creating healthcare companies and things like that. And so I think that, some folks are monetarily incentivized to make sure that they like roll out all these AI powered tools. So I think that there are a lot of people, who are making like, AI powered therapists, AI powered companions, et cetera, et cetera. And I think that can be done, efficiently, safely, thoughtfully, but also at times like it certainly isn't done thoughtfully or safely. And so, I definitely see potential in the mental health care space, but I worry about some of like the irresponsible deployment of some of those technologies, while also recognizing like some people can do that well.
Great. So I think we are done with all the questions from our side. So before closing up, I like to go back to Declan to hear his final thought on the topic of ensuring AI safety and vulnerable users in mental health. What's your final thought, which should go to the listeners of this and those who will be future listeners? How you see that AI is going to impact in mental health?
I think that it's like doctors need to just sort of like, I think, step out of the clinic every now and then and share the expertise that they have trained so hard in school, residency, fellowship. I think that we have so much expertise that the outside world would benefit from hearing and oftentimes really does want to hear, but sometimes we're so busy that we never turn to sort of like share that expertise with anyone else. And so for me, like, I think I'm hopeful that, as clinicians start to do this more and more, that we're able to like make sure that these AI powered tools are going to like support patients and support providers, as opposed to sort of being like a new version of the EHR that just becomes onerous for like most everybody involved. So yeah, no, my call to action is I think folks should certainly be doing that more of that interdisciplinary work. And I think as we do it, I'm more hopeful about this technology being integrated into healthcare in like a responsible and effective way.
Yeah, I think that's a way we have to see that the technology is going to complement clinicians instead of replacing them. So the doctor who are AI empowered is going to replace the doctor who is not using AI. So that's a good way of seeing that. So with this concluding thought, I like to go to Dale and hear his closing thought.
Well, I'm still one of these. I'm still this person that's examined the rapid change in technology in the last 30 years and how society has tried to keep up. And I think the healthcare system in the United States that has some of the worst outcomes and some of the highest costs per person is already challenged. And so I'm just concerned that this not become another money, it's just, capitalization of a tool. So I'm very appreciative of what you've offered. And I'm not sure, I think there's that other whole dimension of how do we prevent some of these negative outcomes that, we've seen in other areas of healthcare. So that's I don't want to be a downer, but
I think it's healthy. I think it's important to have that view.
Thank you, Dale, and thank you, Declan. It was great to hear, Declan, your thought, and thank you so much for viewers. And great, Declan, joining you and hearing your thoughts on that. And we are very grateful for that. And we'll get back to you with more information in the future and look forward to having such continued engagement in the future. Thank you so much. Have a great evening.
Perfect.
And
thank you both so much.
Have a great journey.
Bye.
Bye-bye.
Thank you.